Okay, so I was asked to talk. Well, I was given a few topics to think about, and I thought, well, actually, I'll talk about acute liver failure. Based on the fact at the Royal we have quite a lot of liver failure patients coming through our unit, especially in the last sort of 12 to 24 months with COVID and people's alcohol intake have gone up quite significantly. And I think that that's probably something we're going to see a lot of. But I think it's important to make the distinction between acute liver failure and liver failure related to alcoholism, because they're totally different. They have different prognosis and mortality and things. So I thought, well, I'll have a chat about acute liver failure. It's a massive subject. I mean, you can go into huge different aspects of it. I'm going to just go through briefly what I think is important and how we should manage it. I mean, we at the Royal, we are a liver centre in terms of we've got hepatology on site, but we're not a transplant centre. So I hope that's all right. I looked at the FICM criteria for all of the FICM curriculum for managing and recognising a patient with acute liver failure, and this is what it's got in there. So if you're doing your FICM exam, there's a lot to cover, okay? And I've highlighted some of the things that we'll hopefully cover here today. But a lot of the management and treatment of acute liver failure is very much covered in quite a lot of the generic ICU aspects of care. So we'll talk about a bit about definition, which I think is really important. We'll go through the common etiologies, and then we'll talk about presentations, complications, prognostications, any specific treatments there are, and you know, who should we be referring to the liver units, and any sort of scoring systems that they use for transplantation. So it'd be nice to make this interactive, but it's very difficult to do that with Teams. But in general, the definition is there's lots of different definitions of acute liver failure with differing timescales. But overall, most definitions have liver failure within 26 weeks of presentation. And also encephalopathy with severe liver injury. Synthetic function is really important. So the INR is a very good marker of liver disease and severity. And it's important they shouldn't have any pre-existing liver disease. And sometimes in the history that's very difficult to determine. Especially if patients are heavy drinkers and they come in with acute liver failure, you don't know whether they're acute on chronic liver failure, which has different treatments and prognostications. So those are sort of general definitions. Okay. The speed of onset can help determine the cause. So in your history taking, it's important to get that speed of onset. It can also, the speed of onset can also look at prognosis and determine prognosis, and that's probably related to the fact that different diseases causes different sort of presentations. So, for example, hyperacute has got a better prognosis, and that's often the paracetamol overdoses if they're treated quickly, whereas the more chronic indolent diseases which cause the damage over a longer period of time have got a poor prognosis. So the O'Grady system is pretty much what we use in the UK, that I'm aware of anyway. People put their hands up if they think that's not the case. But the O'Grady system looks at hyperacute, so that's like within 1 week, and acute, which is between sort of 1 and 4 weeks, and then subacute from 4 to 12 weeks. So it's important to try and sort of distinguish whether they are, and if you're over 12 weeks, then you've probably got a bit of underlying chronic liver disease. So, you know, it's important to distinguish those facts. There's different systems, and there's often different nomenclature to all of these as well. So there's, you know, hyperacute, and then there's sort of fulminant failure. There's loads of different things, and there's sort of Japanese system there. You can there's loads of other just different systems. I think from our perspective, you know, hyperacute and acute is really important to distinguish. Okay, so etiology. Drugs or viral, pretty much. All the others are very small. Alcoholic hepatitis we see a lot of, but often that is just acute on chronic disease rather than actual proper acute liver failure. Then there's the sort of more smaller but important things, especially HELP syndrome with pregnancy, veno-occlusive disease, Budd-Chiari syndrome, portal veno-occlusive disease. Surgery. So one of my first sort of experiences of severe hepatic failure was at the General as an SHO, and somebody had an extended hemihepatectomy and went into full hepatic failure very quickly. And I don't know whether you're aware of the problems that they had in Nottingham a few years ago, probably like 6 or 7 years ago, where for their spinal patients in they were using horsehair bolsters, I believe, and they had a number of deaths where patients went into severe acute liver failure within sort of, you know, a few days of having spinal surgery, and they were having direct sort of pressure on their liver and necrosis, liver necrosis. And actually, it got to the point where I think the police were called at one point, and there was a consideration of putting cameras up and things, and you know, they thought that there was somebody sort of contaminating the anaesthetics. I don't know whether anybody was at Nottingham at that time, but it was quite big. But it was thought to do with prone positioning with the bolsters that they were using. And I think Mark Ciccani did a study on it as well and looked at liver flow using bolsters in the prone position. Sepsis important. Death cap mushrooms, they're quite common around the UK, and they look like sort of normal edible mushrooms, but you know, that's an important thing because their prognosis is different from others. And what we see a lot of is the sort of transaminitis from multi-organ failure and vasopressor use, but they tend not to cause liver failure as such, but you do get a significant raises in your ALT and ASTs. Okay. So drugs. This is the sort of commonest thing in the Western countries. In fact, I think I've got the figures here for the UK. About 57% of acute liver failure cases in the UK is due to paracetamol overdose, and that can be, you know, it's a dose-dependent thing, but quite often the unintentional or staggered doses is worse than a single dose. And obviously the unintentional overdose often presents late, and so you can't get the specific treatment in. Other causes in the United Kingdom, you know, that hepatitis A is very small cause, about 2%. Hepatitis B is about 5%. But there's quite significant of idiopathic or unknown causes of, and that's about 17% of acute liver failure cases in the UK. Other drugs, there's a massive list. If you just go onto Up to Date, there's a huge page of drugs that can cause acute liver failure, including some quite common antibiotics that we use, non-steroidals. Obviously, if you're thinking about social drugs, MDMA, and some antidepressants as well. And in the UK, about 11% of acute liver failures are due to these idiosyncratic reactions to other drugs. So it's important, you know, 10%, over 10% really. So you need to have a think about those. So in Asia and Africa, viral hepatitis, sorry, is the most common cause of acute liver failure, especially A and E. Hep B doesn't often cause it on its own. It normally is a cause of acute liver failure, especially in patients that have had immunosuppressants, post-transplant patients, that sort of thing. And Hep B can be difficult to detect on just routine serology. You have to often look at the sort of surface antigens and things like that to actually diagnose it properly. Hepatitis C itself doesn't cause too much in the way of acute liver failure, but combined with hepatitis B can do. Other viruses you need to be aware about. Obviously, Epstein-Barr is quite common. Well, quite high prevalence, but not common in terms of acute liver failure. And all of the other ones here, those so varicella, cytomegalovirus, parvovirus, adenovirus, all of them can cause acute liver failure. So as part of your workup, really, you should be doing serology on all of these. So shamelessly stolen from Up to Date, there's a mnemonic cause for acute liver failure, which I think is quite good actually. Actually having a think down myself, is hepatitis A, autoimmune hepatitis, mushroom poisoning as a, and you can just go down them all really. One thing I didn't mention is Wilson's disease, so just be wary of Wilson's disease as a cause of acute liver failure. So especially patients with a history of cancer or malignancy, you need to start thinking. The commonest malignancies really are sort of breast cancer. They can cause quite significant infiltration. So how do they present? Well, they present sort of depending on the underlying cause, really. I think, whenever you've got somebody that presents to you, go through the whole history, examination, investigation, timing is really important because it not only gives you the prognosis, but also the potential causes. And you need to just go through the ingestion, family history, social, all the normal sort of history stuff that you do. The symptoms are very vague. They're sort of nausea, vomiting, lethargy, just not being very well for last week, sort of almost like viral type sort of presentation. Don't forget to take a very clear medication history. From the sort of examination perspective, it's important to recognise that chronic liver failure signs might be absent. Well, they probably will be absent because this is an acute thing. So you won't get the sort of portal hypertension signs with the Kappa-Medusa and all the spider nevi and all this sort of thing. The most important part of your examination really is whether they're encephalopathic or not. And that's something you need to determine very early on because it guides your management of them. Patients who go on with grade 3, grade 4 encephalopathy go into multi-organ failure very quickly. So make sure you have the definitions of encephalopathy in the back of your head when you're seeing these patients. So as we talked about encephalopathy, so about 25 or 30% of grade 2 encephalopathy have got a rising ICP at that time. The underlying reason for the rise in ICP is probably multifactorial. We always talk about ammonia levels, but actually ammonia, I mean, it's quite significant, but there are other factors as well, including other amino acids and cytokines that are released. But also cerebral hyperemia and intracranial hypertension is also a cause of the ICP. And they often have that sort of classic Cushing's triad as well of hypertension, bradycardia, and so it's important to when you're evaluating them from a cardiovascular point of view to look at those things. They often have a significant blood-brain barrier disruption, so these osmotic particles can get across and cause worsening edema. Classically, from a cardiovascular point of view, they're almost like aseptic patients. They have a low systemic vascular resistance, and quite often they have a high cardiac output as well, so it's almost like a high output state. They have leaky capillaries. They're often dehydrated when they turn up to ED or turn up to the medical wards. because they haven't been very well for the last week or two, but also the leaky capillaries and edema will reduce their intravascular volume. So you need to think about their intravascular status when they first come in. As with sepsis, they may have a element of adrenal insufficiency. So that should still be in the back of your mind as well. Respiratory, they can have acute lung injuries, ARDS. They quite commonly get aspiration pneumonitis, and so that's why I come back to assessing their neurology when they first present. So if they're patients that you would escalate on and they have got some sort of grade 1, grade 2 encephalopathy, think hard about early intervention in terms of protecting their airway, especially if they've been accepted by the liver unit, because they can deteriorate very quickly. I've had a number of arguments with the liver unit over the years where they've accepted somebody from, say, a medical ward, and they want them intubated, ventilated, and all the lines put in before they're transferred across. Often that just causes a delay in their transport, if I'm honest. But you just need to be aware that they can deteriorate very quickly and they can aspirate, and that can cause quite significant problems, especially if they're a transplant candidate. Hepatobulmic syndrome is more to do with the subacute liver failures and the chronic liver failures, but that's normally a pulmonary shunt syndrome, which does improve with transplantation. So obviously with the liver failure, the functions of the liver, I'm sure if you all know the functions of the liver, but there's lots of different aspects of the liver. There's the metabolic aspects in terms of carbohydrate metabolism, gluconeogenesis, lactate metabolism, albumin synthetic functions, so INR, all these sort of coagulopathies, ammonia, they break down ammonia to urea. So whenever you've got an organ that's failing, you just need to think about the organ function and the consequences of those functions not working. So they'll be hypoglycemic, they'll have a hyperlactatemia, they'll have high ammonia, which obviously can have that problems with encephalopathy and raised ICP. Pancreatitis is something that we don't often think about as well, so they can have ongoing pancreatitis with their liver failure, especially with severe paracetamol overdoses, so it's something to have in the back of your mind. The liver is really important from an immune perspective, and patients with acute liver failure or liver failure in general, their overall cause of mortality is sepsis. So it's really important to think about all of your sterile procedures, monitoring for sepsis and treating sepsis. That not only they have impaired function of their leukocytes, but also the important part of their spleen and their sort of portal system there. Metabolically, these patients have a high metabolism and their energy expenditure, and they're often in a catabolic state, so they're breaking down their protein early on, and they do have, obviously, as we know from an anaesthetic perspective, impaired drug metabolism. That's something in your mind. So think about your shorter acting drugs when you're trying to assess their neurology, if they're intubated and ventilated. So hepatorenal syndrome, more associated with chronic liver disease than acute liver disease. Again, virtually all renal dysfunction will improve with the resolution of the acute liver failure itself. Again, it's difficult to distinguish between acute kidney injury due to sepsis and acute kidney injury just because of their liver disease. So it's important to think about sepsis when these patients do present with renal dysfunction. Okay, so what are we going to do to investigate? Well, it's normal, comes down to sort of liver screens, bloods, all these things that we've just gone through. In terms of what happens when the liver fails, you need to start investigating what the cause of it, and also the outcome of that cause. So the liver screen really contains like a viral panel, bloodborne infections as well, autoimmune panel as well, and looking at ceruloplasmin for Wilson's disease. Don't forget paracetamol levels, and don't always believe paracetamol levels. So if you've got a low level, that doesn't mean to say that it's not paracetamol induced liver failure. The liver has a huge importance in electrolyte function, so and micronutrients as well, storage. So make sure that you do all your use needs, looking at your sodium, your potassium. They're normally hypokalemic, hyponatremic, and your liver function tests. So some of your liver function tests can give you an idea of what the underlying cause is. So if you've got a very high ALT, for example, that could be a hypoxic cause. Paracetamol again tends to give a reasonably high ALT, and some of the other causes like viral causes and things don't necessarily give such a high transaminitis. You do a blood gas not just for hypoxia and CO2, but also for lactate. Don't forget pancreatitis, as we talked about, so making sure you're doing your amylase, and rule out as many treatable causes as you can. And with women of childbirthing age, think about pregnancy and the complications of pregnancy as well. Some people suggest that you should be doing an echo. I think that's probably as part of your cardiovascular examination or part of your cardiovascular assessment. And chest X-ray, as part of your sort of routine looking for sepsis and other underlying causes. It's reasonably important to do an abdominal ultrasound, especially looking at Doppler studies and looking for portal flow and hepatic vein flow. Other imaging really would be suggestive of just ruling out other causes. So if they've come in with quite significant abdominal tenderness, you might think about a CT scan because there may be something else going on. Prognostication, well, about 50 to 90% of these patients die despite our best efforts. So actually the mortality is very high. And also the mortality is related to the underlying cause. If the cause is easily treatable, then obviously the mortality would be lower. But it's important to distinguish between acute liver failure and chronic liver disease. And ultimately, if you've got somebody who's come in with a paracetamol overdose, which is, let's say 50%, 57% of our patients will do in the UK, transplantation can save lives. So it's important to treat them early and transplant them if needs be. So severe acute hepatitis and acute liver failure are slightly different disease processes. Now, severe acute hepatitis is essentially acute liver failure, but they don't get encephalopathy. And those patients tend to have a more favourable outcome with supportive measures. Whereas acute liver failure patients that get, the proper liver failure in terms of the synthetic function, INR, etc., as well as having encephalopathy, their outcomes aren't as good. So it's important to distinguish between the two. Also, it's important to distinguish thinking about alcoholic hepatitis and acute alcoholic hepatitis, because some people advocate the use of steroids in those sort of situations. Alcoholic hepatitis tends to be with patients that do have underlying alcohol related liver disease, so they don't really feel fall into the ALF criteria. It's very rare for somebody just to go out and get so drunk that they get alcoholic hepatitis without them being an alcoholic. So I thought we'll just talk a bit about raised ICP management. It's pretty much the same as how you would normally treat ICP. There's a few slight things that you might think about. I think some units do consider using ICP monitoring. Obviously, we haven't got that in our unit, and I'm not sure whether they use it routinely in Birmingham either. But going through the literature and things, a lot of people do suggest that they should consider early ICP monitoring. Anybody with grade 3 or 4 encephalopathy, you need to consider early intubation and transfer to a transplant centre. And I would suggest, really, if somebody it looks like they're going into fulminant hepatic failure when they present, and they would be a transplant candidate, they probably just need to be transferred early. And it's quite shown that any increase in ICP in these patients is very consistently followed by severe multi-organ failure with acute liver failure patients. So it's often a sign that things are going very badly very quickly. The standard neuroprotective measures still count, so make sure your head up, avoid coughing, think about sort of short-acting drugs like remifentanil, tape your tube, make sure that your neck's not obstructed, control the blood pressure, aim for normoxia and normocarbia, control any fevers, and consider underlying seizures as well, because these patients do get quite a lot of underlying non-convulsive status. So if you're not sort of monitoring for that, then you just need to be considering it. Although there were some studies using phenytoin prophylactically, which didn't change the outcome. But just to be aware that non-convulsive status can occur, especially with intubated ventilated patients. The use of temperature control, as with most of these things, is slightly controversial. There has been studies to show that it does actually reduce the ICP specifically in acute liver failure encephalopathy. And the thoughts that it may actually just reduce the ammonia going across your blood-brain barrier, and reducing the ammonia within your cerebellum, your cerebral system. The only problem, obviously, is it can cause quite a lot of cardiovascular instability, and it can, and as sepsis and infection is quite a high cause of death in liver failure itself, being hypothermic, and we're talking proper hypothermia, not sort of normothermic that we run our post-arrest patients at now. With all to 32 degrees, 33 degrees, you're going to increase your risk of infections and sepsis. Having said that, if you're transferring a patient who's got a raised ICP, who's presented to your hospital quite early on, then actually it's probably a bridge to transplant. So it's probably reasonable to keep them on the cold side. Hyperosmotic agents, so mannitol, hypertonic saline, they do reduce your ICP. So think about using hypertonic saline and mannitol. But again, probably as a bridge to transplant rather than improving their overall mortality. So other measures, really, we've seen all the causes, and it's just treating the cause. Obviously, N-acetylcysteine we all know about in terms of paracetamol overdose. It's broken down to, I think it's cysteine, I can't remember now, but it's essentially how it works is it replenishes your glutathione. Now, glutathione is used to bind up the body. It's a body sort of mechanism of binding up toxic metabolites, including the metabolite of paracetamol that causes most of the liver damage. Paracetamol itself can cause direct liver damage, but it's toxic metabolites that cause the liver damage, and glutathione is a natural way of binding up these, but it gets deplenished very quickly with paracetamol overdose, and that's why N-acetylcysteine is good to just keep that glutathione in your body. In the non-paracetamol acute liver failures, there was an RCT done in North America which showed there's a reduced mortality, especially with the early grade sort of encephalopathies, grade 1 and grade 2. So overall, it might just be worth giving that to all patients with acute liver failure, especially as you might be slightly reassured that there's a low paracetamol level, but that doesn't necessarily mean that paracetamol hasn't contributed or is the cause of the acute liver failure. So I think if in doubt, just give it. is my sort of that's probably a non-scientific way of looking at it, but I don't think it has a huge amount of side effects, so so consider it. The rest of the sort of treatment really as a bridge to transplant is just supportive. So, you know, make sure that your blood glucose is okay. They do get hypoglycemic. Keep assessing the volume status as you would with it. I mean, I think acute liver failure patients in general is a really good way of good ICU care. These are all the supportive things that we should be doing to all of our patients anyway. So look at their volume status, you know, exclude sepsis, make sure that, you know, the lines aren't too old, make sure that, you know, whenever you're doing a procedure, it's all fully asepsis. A lot of people don't say you don't need prophylactic antibiotics. However, whenever I've talked to Birmingham about these patients, they want tazocin and fluconazole before they come across. So they seem to, that's probably part of their protocol. And enteral feeding early, make sure that they are catabolic, so they're going to be breaking down a lot of their proteins and muscle and things. And there's some people that suggest that you reduce your protein amount with when you've got very high ammonia levels. We're talking over 150 really. So that's just something to have a think about. Vitamin K, but overall don't correct the INR. Okay, so we should be not correcting INR, especially for lines and things like that, unless they're bleeding, severe bleeding. And the reason is the INR is a really important part of synthetic function monitoring, and so it really muddies the water. Going back to sort of paracetamol overdose, somebody once told me, a hepatologist, that if your PT in seconds is greater than the number of hours since your paracetamol overdose, then you've got a very high risk of death. I don't know how true that is, I haven't researched that, but obviously if you can't monitor your PT, then you can't really assess that. As with chronic liver failure patients or acute on chronic liver failure patients, we're often starting with a lot of lactulose and trying to get them to poo huge amounts of liquid, and also looking at you know, enteral antibiotics like rifaximin and neomycin, but in generally for acute liver failure it's not generally recommended, but you know, obviously if somebody's bunged up you need to get the bowels moving. Renal replacement therapy, the indications would be for, as with any other indication, but think about patients that have really got, you know, that are acidotic, the hyperlactatemia, they'll probably need early renal replacement therapy. And we just discussed that. I'm not going to go through cardiovascular and respiratory support. You should all be able to do that by now. So what else is there around? Well, there's extracorporeal, but there's the MARS, which is the molecular adsorbent recirculation systems. It's been around for some number of years, and I think at the General once years and years ago they trialled it for some of their post-op hepatic resections. It doesn't really change much. It may be there as a bridge to transplant again. So I'm not sure if Birmingham use it. Somebody might be able to tell me, but essentially, if anything, it's just there to delay the inevitable, or a bridge to get them a new liver. There are other artificial hepatic assist devices. Some of them have sort of, you know, liver cells on them. And I think one of the problems with these extracorporeal devices with the liver is it's not the same as the kidney. You know, the kidney doesn't have a huge amount of synthetic function apart from sort of the RAS system and things, but the liver itself has got such an important aspects of synthetic function that these filtering systems that we use will never replace what the liver needs. So there isn't a huge amount of benefit in these devices. So transplantation criteria, you know, it's the important factor is age. Okay, underlying cause, because obviously if they've got a systemic cause which is going to just continue to attack the new transplant, then it's probably not worth transplanting. And doing degree of encephalopathy. So with the encephalopathy itself, so if you've got a grade 1 or grade 2 encephalopathy, you've got about 65–70% chance of a spontaneous recovery with supportive management on ICU. Grade 3 is 40–50%. If you're grade 4, then you've got less than 20% chance of spontaneously recovering with acute liver failure. So, which is pretty significant mortality risk. One of the prognostic models they use is the King's College criteria, and that sort of splits it up between paracetamol toxicity or other etiologies. Now, if you've got paracetamol toxicity and you're in acute liver failure with a pH less than 7.3 or a lactate greater than 3, they're patients that you would consider for liver transplant, or 3 of the following conditions within a 24-hour period. So presence of grade 3 or grade 4 encephalopathy, INR greater than 6.4, creatinine greater than whatever that 3.4. Other etiologies is a bit more, have a stronger indication, as in a very high INR greater than 6.5 and encephalopathy present, irrespective of grade. So that's why INR, monitoring the INR is really important from a liver perspective, in terms of, we shouldn't really be giving, if you've got an INR 5, you think, oh, I'm not going to put a central line into that person, but with acute liver failure, you really need to think hard about reversing the INR, because it does actually affect whether the patient could have a transplant or not. So just be careful about the sort of automatic trying to correct things. The other scoring system, which was designed really for more chronic liver failure, is the Meld Score, but actually that has compared well with the King's College criteria for acute liver failure. And they look at sort of the Meld Score greater than 32 is used to predict mortality. And the Meld Score, if you have a look at the actual the equation itself, it involves logarithms and factors and things, but it's essentially your creatinine, bilirubin, and INR again. So INR is important not to correct. And actually, when you talk to the hepatic registrar, that's the first thing they say. The transplant registrar is like, well, have you given anything for the INR? Okay, so that's a very quick whistle stop tour of acute liver failure and what we sort of present in ICU. I think that the take-home points really is, please establish the time frame, and whether it's a proper acute liver failure or whether it's a chronic, acute on chronic, or a chronic liver failure, because the outcomes and the management are different. Chronic liver failure, say alcoholism or whatever, you might give them a trial in ICU and see how they go, but the acute liver failure patients need to be transferred to Birmingham quickly if they've been diagnosed quickly. So it's important to make that distinction. Investigate cause, supportive measures, try not to correct the INR. I know I'm going on about that quite a lot now. Early liaison with the liver unit, and think about intubating and protecting an airway early. If you've got somebody who's coming with acute liver failure and they're already encephalopathic, the chances are there will be a multi-organ failure within a few days, 24, 48 hours. So you think about protecting their airway, rather than sedating them to put an NG tube down, because they haven't, all that sort of stuff, which puts them at risk of aspiration. And have a low therapy for acetylcysteine. Okay, I think that's it. That was quite quick, I'm afraid. Any questions? Anybody want to have any discussions about anything? No, stunned silence. Always good.
Thanks, Alex.
Just a quick one, Alex, just to say that completely the INR bit. I used to many moons ago. I was at the Birmingham liver unit, and they used to really stress the importance of not correcting INR. Even putting central lines with INRs of 7 and 8, they just go ahead and do it without correcting it. It was that important in those days, which I guess it still is. And they did use MARS in those days. I'm not sure if they still do. I'm not sure. I haven't looked at data or evidence for that recently, but they did use it in, this is going back, gosh, 15, 20 years now.
And were they using it for bridge to transplant, or were they just using it as a,
Yeah, as a bridge to transplant.
I think that's probably still has a role there, doesn't it?
Yeah. But definitely the thing about INR and correcting INR, they'd be really, really annoyed with you if you corrected INR and then put somebody in the back of an ambulance down to them.
Yeah.
Just put the line in first time and then it's not a problem.
Yeah.
Fingers crossed. Yeah, don't put a subclavian.
Yeah.
Yeah. We think we might have torn a subclavian artery recently at Glenfield. So, yeah.
Well, Dr. Lau got me to put a subclavian central line in when I was an FY1.
That's Dr. Lau for you.
I know.
Well, there's a new way ultrasound guided. You can put on central lines in the subclavian as well. It's very easy. It's called as a tadpole sign, where it's very easily you can put subclavians infraclavicular approach. I'll be happy to demonstrate that. I'll make a video of that and demonstrate. Question for you, Alex, if I may, please. I really like that, this non-paracetamol poisoning, but the benefits of N-acetylcysteine. I just wonder, is there a set protocol for any of those which can be used? So I remember I think a couple of months ago, we had someone who was a patient who was transferred across from Royal, and they came to us, then they thought of a surgical cause, but surgeons, they said, no, there's nothing surgical. She stayed with us, and later we came to know, I think Rob identified, having had a chat with her husband, that she had taken significant amount of paracetamol. But initially, because we couldn't just think of anything, and it didn't strike us, and it just felt like that. We could have given.
I don't think there's a set protocol as such in sort of outside of the unit on obviously with the use of specifically in paracetamol overdose, yes, but I mean I've always got a low threshold of using it. I think if if you don't know what's going on and it's a young fit person who's coming with acute liver failure, just give it, because as you say, over 50% of the time you'll be correct based on the stats that 57% of the patients who present have got some sort of paracetamol toxicity. So yeah, I would encourage people to use it. I'm not convinced that there's huge amounts of side effects that's going to cause major issues with it. So yeah, is anybody on a trust compute can have a look at the guide? But the guide
had a new one, didn't they?
That's fine. I'll find out. No problem.
Yeah.
The AD started the new one, so rather than having the 23-hour one, it's over 15 hours, and you just keep giving the last bag on the thing for us until their INR is better.
Yeah.
I think unless it's changed in the last 6 months while I've not been there, but that's what we always used to do.
I think one of the problems we get with these patients, we've got so many liver failure patients coming in now, and actually determining the ones that have actually got acute liver failure, which really needs to be sorted, compared to the sort of chronic liver failure, is difficult. Mike, you got your hand up. And Ravi. Mike first.
It wasn't Mike. It was me.
Oh, hi,
the liver units certainly actually just give NAC a lot of the time.
Yeah.
I think I agree entirely. If you've got someone with acute liver failure and you've got an unknown cause, you just bloody give it, because it's pretty benign. If you've got a clear cause, then you don't worry about it, do you? But the liver units, certainly last couple of times I've talked to them, or at least they've been spoken to and then I've been involved, they've already suggested give it.
Yeah.
They've always been really helpful whenever I've spoken to them.
Yeah, it's interesting they always insist on tazsinafluconazole though, because going through the sort of the evidence based on it is very, I suppose surgeons want, I suppose it's the same with max fax wanting 5 days of augmentin, I suppose. But Ravi.
So just a few points. On the issue of NAC, liver centers do use NAC, and they use it at a standard dose of 150 milligrams per kg, and they continue it until the INR comes down to like less than 1.8 or 1.6, and that just carries on because.
Is that for all patients, Ravi?
For most of the patients, despite the etiology of liver failure. I mean, obviously, paracetamol, there used to be this sort of 1 hour thing, 12 hour, and then the subsequent thing. I think that's now changed, as Zoe was saying, to a 2-dose sort of broken down into sort of 2 regimens. But for all non-paracetamol or where the etiology of liver failure is not known, they use NAC at a dose of 150 milligrams per kg until the INR is sort of back to 1.6 to 1.8, because the risks of NAC are actually quite low. I think the only one that I can remember is it can cause some bronchospasm in some patients, but that's the only thing. On the issue of the bridge therapies, I don't think Mars is used that often these days. At least I've not seen it when working in London. But what they do use is high volume plasmapheresis. Okay. So there's a lot of sort of pro-inflammatory cytokine storm that happens in acute liver failure, and that in fact is the cause for the multi-organ failure, be it respiratory, intracranial hypertension, and all of that. So they do have. They do use high volume plasmapheresis as a bridge for transplant in quite a few cases that I've seen in the liver unit, and everyone is advised to use fluconazole for all the referrals that come across to liver centers. That is standard. I'm not sure what the evidence is, but they're obviously immunocompromised with liver failure, so that is there. But one thing which they take very seriously is the risk of intracranial hypertension. So just a whiff of alteration in their GCS, they just sort of straight away intubate those patients. And they have a set of measures called fulminant measures. So include all of the standard neuroprotection like deep sedation to RASS of -4, -5, paralysis. And they do give hypertonic saline, aiming for a sodium of 150 to 155. So it's 30% saline that they use. And they target the sodium of 150 to 155.
Yeah. Thanks, Ravi.
Wow.
Yeah, Birmingham also used to use 30% saline. And again, this is going back 15, 20 years, and aim for a serum sodium of about 155 to 160. So that hasn't changed then.
Mike?
Okay, if you've got an intubated patient, then how are you going to assess their ICP in a centre that doesn't do ICP monitoring?
They don't assess ICP, they don't measure ICP because the risk of bleeds apparently with ICP monitoring has been more than the risk of any benefit from measuring ICP. So what they, rather than doing that, they just keep them sedated for at least sort of 2 to 3 days. They continue to monitor their sort of liver functions and INR, and either they transplant them and then wake them up, or if the INR is sort of showing a trend of improvement, then they sort of gradually reduce the sedation and wake them up. But I've had a discussion about ICP monitoring, and they used to use it a lot previously, but apparently the risk of bleeds has been more when compared to the benefits from routine ICP monitoring.
I can tell you from somebody who's had ICP monitoring that before, when my first CT, I did not have a subdural, and then after they put an ICP bolt in, I did have a subdural. So
first-hand experience there.
Yep.
Coincidence.
You can turn out okay though. Fine.
Yes, it did turn out okay.
With the sodium, it always used to be that they aimed at 145 in the awake patient. The 150 was only when they'd already had a sort of element of conscious level derangement, and they were actually concerned about ICP.
Yeah.
Have you changed that, Ravi, or is it still 145 and above?
No. So if there is a risk of intracranial hypertension as evidenced clinically by an alteration in their GCS, then they get intubated, and that is when they aim for a sodium of 150 to 155.
But they're still aiming at 145.
Yeah.
When they're yeah. So yeah. It's one thing we're probably not very careful with, and we let the sodium sometimes drift down into the 130s. We really probably need to be don't, because it confounds the whole picture.
But I mean, to be fair, we don't often keep the acute liver failure patients, do we? They go. I mean, what we see is the chronic liver failure patients that have got that sort of aldosterone deficiency and hyponatremia and crappy, you know, and to try and keep their sodiums, the chronic liver patients' sodiums up is actually really difficult.
I'm actually talking about the acute ones. We do.
So I can't eat.
All right. We often get a few that sit around for 3 or 4 days before they go,
Yeah,
or that just are starting to improve, and we probably just need to make sure that we're sticking to those.
We don't keep 30% saline though, do we? That's one of the problems.
Not saying that.
We used to use all the time in Australia, in Adelaide for ICP, when we had sort of most intracranial, but normally you had an EVD or a bolt in, and you'd give sort of 20 mils of 30% via central line and see what the response is.
And the other sort of quite problematic thing in acute liver failure and fulminant hepatic failure is management of ARDS, because very often they do get ARDS, and if you're faced with a patient who's got intracranial hypertension and ARDS, it's quite difficult to achieve lung protective ventilation in those patients, because you can't do permissive hypercapnia like other ARDS. And I've seen quite a few patients that have bailed out by using ECMO waiting for transplant.
So that's interesting. ECMO is a bridge to transplant in that sort of respect.
Because they are genuinely difficult it's quite difficult to manage their ventilation when they develop ARDS, and they also have evidence of encephalopathy.
Seems like the sort of patient that might get a bit complicated for ECMO. They might not be unkeen.
But it has to be in the same center, I guess, where they can do transplant.
Yeah.
Cool. Anybody else got any questions? Gonna guess not. Oh, here's the feedback slide if anybody wants to sign in, so that Dr. Keeshan can have some nice feedback. Unfortunately, there is, like we said, there was a bit of a communication problem with Journal Club, so it's not happening this week. So that's partly my fault. Next week, Emily McGamby is going to be talking to us about chronic liver failure, so it'll swing in nicely after the acute liver failure. So hopefully that will go well. But people should carry on with work or go enjoy the sunshine if they're not at work. Apologies to those that are.
Oh, sorry. I wasn't muted.
No, you weren't.
All right, thanks guys.
Thanks,
Alex.
Thanks everybody.
Bye.
Thanks, Alex.